All right. Hi, everybody. My name's Tommy George. I'm a practicing epidemiologist at a local health department in Nebraska. Hopeful 2027 doctorate in public health and epidemiology graduate. And some of my work is in the rural settings, helping with improving systems of care. So today I'll be going through how we may evaluate a rural hypertension control program that uses a nurse follow-up model of care by incorporating the REAIM and CFIR frameworks integrated together. So first, I just wanted to go through some background. Uncontrolled hypertension is very common, impacting roughly half of adults in the United States, as of a report published in 2020, referenced at the end of this presentation. Even with that, some research has shown that higher prevalence of hypertension among rural residents in the United States, which may be due to many factors unique to rural healthcare. As a result, I was examining how improved care coordination with rural residents may help improve hypertension control under a model proposed with regular nurse follow-up via structured interviews between visits. So this pilot project specifically starts when an individual is diagnosed with hypertension in the clinical setting. After that, nurses conduct 2 calls every 2 to 3 weeks between that initial visit and their final visit. Here on this slide, you can see the components. They introduce themselves, address the patient condition, assess their blood pressure readings and adherence to goals. They reinforce healthy behaviors and assessments of referral needs, and they review and revise health goals. They end a call with words of encouragement and schedule the next call. And that last call occurs before follow-up, before their follow-up visit after that initial diagnosis, which is about 8 weeks. So we examined an RCT of this program using the REAIM framework. For this, we can do the same. We can look at reach as the number of patients and nurses included in the intervention. The effectiveness can be described using the metric of hypertension and its status at diagnosis and each follow-up interaction. Adoption can be examined by how many nurses or providers are incorporating this model into their practice. Implementation can be assessed by incorporating fidelity assessments into the program. So this may be done by reviewing electronic health records and clinical documentation by the staff at their encounter. And then finally, maintenance could be measured by how many sites adopted this model and continue to use the model. So we can also look at how fidelity was maintained in this component too. So another framework that would be useful for integrating with REAIM is the Consolidated Framework for Implementation Research. I've just been getting familiarized with this as part of this course, but I find it to be a useful way to organize my thoughts. I included this graphic just to show how the settings, both inner and outer, and individual characteristics are all embedded together. We also look at the process of the intervention being implemented and the characteristics of the intervention itself. So this helps organize the way we look at interventions being implemented. And the next slide, I'll show how we may integrate this framework with REAIM. So this slide is a bit difficult to read, so I apologize for that. I just wanted to go through each component of CFIR and discuss that it may be tied back to REAIM in a range of ways that we can decide on as the proposal comes along. So first, I'll talk a bit about the outer setting. This could be an examination about values and beliefs, partnerships and connections, may impact reach or how it may impact adoption of the model. Really, we can examine a lot of different things like how incidents, policies, laws, values, beliefs, partnerships, financing, and just a host of other external factors impact any of the REAIM components. The inner setting is where we could look at organizational culture, like tension for change, like people who really like innovation and people who are a little more risk averse. Incentive systems, mission alignment, available resources, and a host of other internal factors of the organization that may impact REAIM components. Third, we can look at individual characteristics. So this might include the nurse or the patient or administrators at the clinics, or even a higher level of clinics are part of a broader network. Or maybe it's related to how they're reimbursed, like they don't want to do the follow-up visit because they don't get reimbursed for that encounter. Like maybe that's something where legislation needs to be passed, or CMS needs to be talked to, and things need to be figured out to be done a little bit differently. Um, so we can examine how the innovation is viewed and how it's incorporated as a result of that perspective. We might ask how much motivation, opportunity, capability, and need exists at the individual level to push us forward on this model. So that's the individual characteristics there. We can also look at the process of implementation. So this is where we might look at how fidelity adherence to the model relates to the re-aim components. So for example, how might 2 calls versus 1 call every 2 to 3 weeks impact adoption or effectiveness? We might ask what adaptations to the implementation process might improve hypertension control and adoption dependent on the setting. And finally, we can look at the actual intervention characteristics, which I kind of just did, talking about the calls, and how those might be tied back to the re-aim component. So we can ask how adaptable the model is and how those characteristics of the model can be adapted and tested. So that's kind of like the trialability, testability of your changes and of your implementation changes. This might be a good place to examine how changes to the model can improve hypertension control or the effectiveness or the reach, like how many patients actually end up doing it. So overall, there's a lot that we can do with re-aim and CFIR combined. It's a huge matrix of things to look at. And the benefits are numerous. Like, as I was going through this, as I was looking at how you might design a study looking at the different CFIR components, which is just super complex, this huge array of characteristics at things at like all levels, it seems like. And then looking at re-aim, like the whole process of how many are we reaching to, like, as we're going through, and how effective is it, like how broadly adopted is it, like how well implemented is it, and then how well maintained is it when it's implemented. All of that, there's that, so complex. So there's so many different things. So I just put a few on here for you to see. So the first one is a better understanding of implementation of follow-up calls on hypertension management in a rural setting. So just specifically for this rural setting, let's say you're doing it in Nebraska, say you're picking a collection of counties, like you're gonna be able to maybe dive further into how to improve those systems of care. So how setting characteristics, inner, outer, and individual impact implementation might be better understood. So like maybe the model itself works pretty well, like if it's actually done, but you can actually dive into like what's happening here where implementation is different. Like what about CFIR tells us about re-aim and vice versa. And then also pilot studies. So practical pilot studies examining implementation will help inform future iterations of improving rural healthcare. Very similar to what I'm talking about before. But the more pilot studies we do in a community, the more we have an understanding of what works and what doesn't. And then finally, we can help identify what future research needs might be out there for promoting hypertension management in these particular settings, like rural settings, and kind of what characteristics generally are impacting it. Like maybe you can then actually look at rural and urban differences too, to better understand it. So just a few implications there. And here I got all my references. The top one was the report. It was using NHANES data. That's where I got my statistics about hypertension. I'm sure it varies pretty broadly across the country. And the second one was talking about the prevalence of hypertension by county, rural, urban. So I'm in Nebraska. They actually mentioned Nebraska in here. So I found it to be a good article for me. And then Chew, it's a 2010 article, which I didn't realize was a long time ago until I saw 2010. But They're just looking at the effects of 8 weeks of sustained follow-up after a nurse consultation on hypertension. It was a randomized trial, and that's where they were using the 2 to 3 calls every two weeks. And they were going through those kind of steps on the call to make sure they're kind of touching on all these key points. And it just seemed like a nice model and seemed like something that might be a good idea to test out. So anyways, that's my presentation. Thank you for your time. If you have any questions, please feel free to reach out.